morning, everyone. How are you? I kind of run our clinical side of our program and the clinical care of many of our patients. So if you're a patient here, you know who I am and hopefully remember most of what I'm going to say. But many people have told me that they don't remember anything that I say when they see me in clinic. So for those of you who've been coming to the seminar for a long time, you can take a nap, go refill your coffee, whatever. But this is, we really want everyone to start the day on the same playing field, that we all know the definitions that our really, really smart speakers are going to use. I don't want you to get bogged down in ablation, what is he even talking about? What is that? What's a holster monitor? All of these things. But other things that you will also see for the day is everyone has on our name tags, and all of y'all have on the white ones. All the speakers will have on a blue name tag. Our staff has on a green name tag, and so if you need help, you can find someone with a green name tag or Crystal or I. And then all of our industry representatives from many different companies working on different things related to ARVC will have purple name tags. So that way you can kind of know who everyone is when you're, need something, you can grab the appropriate person. So we'll get started and let's go through, kind of the basis for everything that you're going to hear today that's going to be much more high level. So we really will start with what does ARVC mean? And I think that this is of particular importance right now because as our fellows will tell you, there's a lot of argument in the field right now about nomenclature. And nomenclature just means what you're calling anything at any given time. And, a lot of people will say, well, no, I was told I have RV dysplasia. What's arrhythmogenic cardiomyopathy? Things like that. So it's at base, we're all talking about an arrhythmic cardiomyopathy. Cardiomyopathy means a heart muscle disease that has a lot of arrhythmias associated with it. Back in the day, they thought it was dysplastic, that these kids' hearts were born that way, but now we know it's a cardiomyopathy. It develops over time, so we dropped the D. Got rid of the D, except for the RV campers have ARVC.com, so we can't move to that. So we're still ARVD.com. But nowadays, we know that it's not just right-sided. Anyone with a desmoplakin mutation might tell you how long they were misdiagnosed because they were told they couldn't have this because they had left-sided disease. And in fact, a lot of our data shows that it's biventricular on both sides of your heart. So the field is also moving towards this arrhythmogenic cardiomyopathy term. So you'll hear kind of a lot of these things thrown around today, and I don't want you to get bogged down into, no, I have ARVC, not I have ALVC, all of that. So as Dr. Hopkins said, we're eventually going to move towards genotype-specific names, or many of you might be gene-elusive, and so there's a lot in the name. So don't get bogged down in that. So many of you may have presented with symptoms similar to this. Some people presented with just palpitations, some people just on screening. You may hear about syncope, which is passing out, cardiac arrest, which is VF, ventricular fibrillation, sudden cardiac death or resuscitated sudden cardiac death when you are able to be revived. So there's a lot of really different ways you can present. There's a lot of other differential in the diagnosis of things that are considered when someone presents with these symptoms. So is it coronary disease? Is it myocarditis, which is just inflammation of the heart? Although now we know that a lot of ARVC can mimic myocarditis or can present with a myocarditis-like picture. There's this condition called cardiac sarcoidosis, which is an inflammatory condition which can look similar to ARVC, and other idiopathic arrhythmias of unknown cause. And then ARVC is one of the things that you consider when you present with these symptoms as well. So how you evaluate that is, you do your catheterization, rule out coronary disease, and then hopefully a lot of these other diseases have specific patterns that we can differentiate from ARVC looking at them. So ARVD was first described by Guy Fontaine and Frank Marcus, who Dr. Hopkins talked a little bit about already back in the 80s, which in the grand scheme of things was not that long ago. That's basically after many of us were born. The diagnostic criteria were first made in 1994, revised in 2010 to include genetics and better MRI specificity. And then in 2020, they tried to make an attempt at a left-sided definition, although it has some flaws to that. And now, as Dr. Hopkins said, we're working on these gene-specific diagnostic criteria. So the diagnostic criteria, whether they're the new ones or the 2010 criteria, are really based on the underlying pathobiology of what's happening at the molecular level, which Dr. Delmar is going to tell you a lot more about today. He knows a lot more about this than I do. But essentially, it's the desmosome, these bolts that hold your heart cells together that have a genetic risk factor, which causes these bolts to be weaker than they should be. Over time, they can break down and cause this scar tissue. So there's a lot of talk about like fat on the heart or fat in the heart, and it's really this fatty, infiltrative tissue. So, there's fat on your heart for a lot of things. So we're really looking for specifics. Many of you may hear me talk about your ECG findings. The first thing that gets changed often when you have that delay across the desmosome is that the electricity gets slowed and the conduction is abnormal. So this is what your ECG should look like with this nice upright T wave, and most of you look like this, that you have this inverted T wave here, which is a valley, really showing some of the repolarization abnormalities in ARVC. Then I call a signal average ECG like a high resolution ECG. It's really looking for kind of those delayed signals. We don't do signal averages on a routine basis anymore because repeated studies have shown that they don't have any independent diagnostic or prognostic value, and they have a lot of false positives. And so this is something that we don't really do anymore. So if you're doing routine signal averages, it's probably unnecessary. We're all about doing studies over the years to learn more, to only have you do those regular tests which are going to give you diagnostic and prognostic information, not just unnecessary tests for testing's sake. One of our favorite things that does have a lot of value is a Holter monitor. And nowadays, there's these great little patches. You don't have all those annoying leads anymore. Those of you who've been diagnosed for a while will remember all of this leads that you used to have to tuck in your shirt and all of that for 24 hours. So we recommend getting a Holter at least once a year. The amount of PVCs you have on your Holter give us so much information about the inflammation and the electrical stability of your heart, and it helps us predict VT. All right, because this is what we all want to avoid, right? Ventricular tachycardia, which is these fast, irregular rhythms that if they're going fast enough can cause you to be really dizzy, pass out, and worst case scenario could degenerate into VF, ventricular fibrillation, which is really dangerous if you're not converted quickly. So then the electrical disease in most patients starts first, at that connection level, and then over time, when the scar gets big enough, it starts to affect how your heart is pumping. And it's not necessarily that we look always for the pumping function to go down. At the beginning, your pumping function would be normal. But what we see is that the scar is really bulging out, or the muscle is really bulging out around the scar. And so you see these kind of outpouchings, or what is called a wall motion abnormality. Biopsies sometimes can show this fatty tissue, but we don't do biopsies a lot anymore because it's a patchy disease and we don't really like taking a bunch of chunks out of your heart to try to find it. We know that we can get a good enough diagnosis with all these other tests without invasive tests like a biopsy. So, genetics. Let's talk about things I like to talk about. About 2/3 of you with a diagnosis, a clinical diagnosis of arrhythmogenic cardiomyopathy, will have an identifiable mutation or pathogenic variant on genetic testing. So genetic mutation is, and I'll talk a little bit about an alteration in the code that we think is supposed to be there. This is then your genetic variant is the root cause of all of these cardiac abnormalities you see. Now there's always confusion about this every year, so I'm going to be very clear. Some new genetic testing techniques can pick up mutations that were missed on old sequencing. So only if your testing was negative. If you have what I have called a confirmed pathogenic mutation, you don't need repeat genetic testing unless something really weird happens in your family. If your genetic testing was negative, meaning you are gene elusive, you do not have a known genetic risk factor in your family, and you have not had testing since at least in the last 10 years, we would recommend repeat testing. Or if you had testing through a company called Familion and no mutation was found, or if it says sequencing on your report. If you've had a confirmed true pathogenic mutation that's tracking in your family, you don't need repeat testing. The likelihood of finding another thing in your family is very, very, very low. But if you have not had an identifiable mutation, talk to me, there's new stuff, is the moral of the story. So what is a gene versus a protein versus in your heart and all of that? So I'll tell you a secret. We all have PKP2 genes. We all have desmoplakin genes. Dr. Hopkins does, I do. All of us have the PKP2 gene. What happens is in ARVC is that gene has a typo in it or a genetic mutation or pathogenic variant. So you have a misspelling in the gene that we all have, but you have the pathogenic variant, and then that causes the protein to not be made correctly because it's like you're making a recipe and you skip some steps, right? So then the proteins in your heart is not made correctly, and then that means that the desmosome, these connections between your heart cells that Dr. Delmar, I'm sure, will probably show you some cool pictures of, does not work properly. Right? So that's how the gene kind of goes to your heart muscle. So genetic testing is when you then look at the gene and run spell checker on it. You're trying to see where that misspelling is, that typo that's not working anymore. It used to be that blood is the preferred sample, but now actually, thank you, the only good thing about the COVID pandemic is all the labs have validated cheek swabs. And so now, based on your state, most of the time I can just do a video visit with you and send you a cheek swab in the mail, and we'll check out for that. And their interpretation of these genetic variants is very important. I have seen 4 people in the last week alone who had mistaken diagnosis, mistaken management based on misinterpretation of their genetic test by their doctor. Doctors don't get a lot of genetics in medical school unless they really specialize in this. I don't know how to read VT morphology. That's Dr. Hawkins' job. My job, and other people like me, is to understand how to interpret these genetic variants. So we really, really recommend meeting with someone like me, and I can try to help you find someone locally if I can't see you on video. And this is a website where you can try to find genetics professionals. So who should get genetic testing? So anyone with suspected ACM or ARVC, and if you find a genetic mutation, then all of the relatives of that person as well. Then we can track it through the family and find out who else is at risk. Just having the genetic mutation doesn't mean that you have ARVC. It means you are at risk. And all of that scary stuff I talked about before is preventable and manageable if we know you're at risk. The major thing that is dangerous is having family members who don't know their risk, and sudden death can be the first symptom. So I really encourage you to encourage your family members to get tested for the risk factor in the family. It's not as scary as they may think. And being asymptomatic doesn't mean anything. You can talk more to me about that later. So again, the results will show a mutation, or the American College of Medical Genetics says that we're supposed to say pathogenic variant now. That's the word that we're supposed to use instead of mutation. But either one means the same thing. It's a risk factor. And again, like I said, there are different types of mutations that I'm kind of analyzing to try to see if this is actually damaging that protein in your heart. Sometimes we're left with a gray area result. This is not satisfying for you or for me. It is this thing called a variant of unknown significance, meaning there is a change in the gene. So there is a typo there, but we don't know what that typo does to the protein. Is it like just switching a red Lego for a yellow Lego in the protein? They still hook together. They still work just fine. The body tolerates that. Or is it like switching a Lego for a Lincoln log? They're both blocks, but they do not work together. And so that definitely can damage the protein. This is what I spend a lot of my day doing. Once you have this genetic risk factor, you have ARVC, I always like to make kind of the public service announcement that if pregnancy or having children is something that you want, it's often safe for most ARVC patients. Of course, talk to me and Dr. Hopkins and Dr. Galotra about what your specific risk is, but I've heard too many people been told that they can't have children. That just isn't true. There is options out there for something called pre-implantation genetic diagnosis to guarantee that you're not passing on the genetic risk factor, but there are pros and cons to this option. I would recommend talking to me a lot about it, and I can walk through all those pros and cons with you. So a lot of people may have family here and family histories that look like this. This is called a pedigree. This is how I draw your family history when you're in clinic with me. So you may have lots of people that have the disease or just are carrying a mutation like this. And so a lot of families look like this, and I call them their own little mini support group, right? But a lot of families look like this. We track the mutation through the family, but only one person has any evidence of disease. This happens all the time, and in fact, about 50% of our patients are the only one in their family with true disease, even though the mutation tracks through the family. So that's not unusual. This is something called reduced penetrance, meaning not everyone that carries the mutation develops disease. And this varies a little bit by the gene, by your exercise, things like that. But we know, especially in PKP2, which you'll hear a little bit about our plans for solidifying data around other genes, that this penetrance is greatly modified by exercise. The more you exercise, the more stress you put on those bolts, and the more potential that you have to develop arrhythmogenic cardiomyopathy. That's a little bit of a simple version. Dr. Delmar might tell you more about that today, but that's kind of essentially how it works. But then we also have variable expressivity. Even in the same family, different family members may have different severity of disease. Someone might just have AFib in their 60s related to their PKP2 mutation, and another family member with the same mutation in the same family has a cardiac arrest at 16, right? All variable. This probably has some to do with environmental factors, exercise, but probably also has to do with genetic modifiers, which we're continuing to try to find. If you donate blood today, these are the sort of things that we're trying to understand why this happens. So now you have ARVC or arrhythmogenic cardiomyopathy. What happens now? Really, then we are going to talk about, with all of our speakers today, what the four-legged or five-legged stool of management is. We need to find out who's at risk and get them an ICD if they need one. Not everyone with ARVC needs an ICD, but you'll hear a lot today about what we call risk stratification, trying to determine who with ARVC has enough dangerous risk to need a defibrillator to protect them from sudden death. And then we have arrhythmia management, VT management. That is not a defibrillator. Your defibrillator does not manage your VT. That is there to save your life, right? VT is managed by medication, catheter ablation, combination thereof. Then we talk about lifestyle adjustment, exercise, other medication, things like that, and then making sure your family is protected as well. And so you'll hear more about all of these steps along the way today. So you're going to hear a lot about different types of defibrillators. There's the standard transvenous defibrillator, which many of you have, which has a lead into your heart. And then you'll hear about the subcutaneous defibrillator, which literally subcutaneous under the skin, goes in your armpit and has leads right under your skin that aren't in your heart. There are pros and cons to each type of device. Arrhythmia management is often done with medications called beta blockers, which block adrenaline, which reduce your risk of arrhythmias. Catecholamines often trigger a lot of these arrhythmias. And then catheter ablation, which Dr. Crispin will tell you a lot about, is actually an invasive procedure. You're not going in and taking out the scar. There's nothing that can take the scar out. But what you're doing is going in and changing the scar, hopefully, so that the arrhythmias stop getting stuck in the scar. And again, that's a simple explanation, which Dr. Crispin will tell you a lot more about. And this is kind of what they're looking at when they're mapping the scar that Dr. Crispin does in the lab. So then the next leg of the stool is we really want to avoid structural progression. Overall, ARVC and ACM are very slowly progressive, right? We often recommend medications which slow cardiomyopathy progression called ACE inhibitors or ARBs, which reduce load on the heart and can slow progression. Dr. Galocha will probably tell you a little bit about these today. I know you've heard enough about exercise restrictions, so I'll have a little plug for that later. But there's a lot of new data emerging now that we're getting better at managing heart failure in our patients. So, technically, if you look at the literature, ARVC patients are supposed to only do these exercises: bowling, cricket, curling, golf, rafferty, and yoga. Now, we know that this does not sound like a very exciting list of things to do. I know that many of you have a great love of doing a lot of these things up here, right? My big message to you is that exercise restriction is not a word that I like to use. I don't like to say you're restricted from exercise because you're not. We still want you to lead an active life. What we do need you to do is modify the types of exercises you do, right? We need you to modify the intensity and the duration of the exercise that you do. And a lot of this also depends on what your clinical picture looks like as well. So exercise prescription. Crystal and I have people who call us all the time and say, can you tell me a list of exercises I can do on a letter for my gym teacher? I'm like, no, because there's umpteen exercises you can do. This pickleball thing, I really don't get it, but it's very popular right now. And so there's a whole host of variation in the things that you can do based on your clinical picture, and we want to work with you to find the balance of what modifications are safest for you. So my goal would be to not come in here and say, oh, I don't want to talk to Dr. Hopkins. He said I have to sit on my butt and do nothing and take an exercise sabbatical, and I don't want to talk to him about that. But realistically, I work really closely with a lot of our patients to find a happy medium. It's not always going to be super happy because, if you want to be an Ironman, it's just not going to work. But we can work together to find something that works for you. Anyway, Dr. Sears is here. We so very much appreciate it. I know y'all love him. But we really encourage you to take care of your whole self. We have done studies that have shown that you guys all have body image concerns, a lot of anxiety, depression, device-specific anxiety, and that this is hard to adjust to. We have proven that. And so we really know that this is further complicated by telling you that you can't do the types of things that make you feel like you. So we really encourage you to have a very low threshold for asking for help, seeking out a therapist, a psychologist. I know it's hard in post-COVID times because everyone needs a therapist, but we really encourage you, it's just as important as doing your Holter monitor every year that you are taking care of yourself from a mental standpoint. We talk about this anxiety cycle, right? That you're anxious, you're not sleeping, you're stressed. That releases lots of catecholamines in your body. These catecholamines give you PVCs. And then you're like, oh, I feel those PVCs, that's stressing me out. Is my defibrillator going to fire? So that stresses you out. Then you have anxiety. Then you have more catecholamines, and you're round and round and round and round you go, right? So we talk about breaking this cycle, realizing what you're feeling, and really working through that with a lot of anxiety reduction techniques, medication, support resources. There's specific trauma-based therapies, especially around device shocks, that I can recommend to you that have been very effective in a lot of our patients. Mindfulness-based stress reduction has been shown to be beneficial in patients with cardiac disease. Yoga, meditation, box breathing. If you don't know what box breathing is, Google it. It's, really this breathing technique to reduce anxiety, and it can be helpful in stopping that cycle. So you're going to have a lot of more information today, and it's really overwhelming. So please email Crystal and I if you have any questions. If you haven't seen us in clinic, I do really strongly recommend it because we've seen too many people over the years that are mismanaged or just misinformed, that nobody has ever explained anything to them. So Dr. Hopkins, Dr. Crispin, Dr. De La Uz, Dr. Galotra, and I and Crystal are all available to see you in clinic to make specific recommendations to you. Today is about the disease in general. A lot of what you hear today may not be applicable to you and may not be what is needed in your situation. You really need someone to look at you and have a specific prescription for how you should be followed. There are a lot of great resources out there. The SADS team is here today. If you don't need them, they're fantastic. There's Facebook groups. I'm also, if you are 30-ish or under, I'm going to get together a group of you at lunch today to talk to each other individually. So find me at lunchtime, and I'll show you where all the cool kids are hanging out. SADS has a lot of opportunities like ICD support groups, things like that, to really help you take care of your whole self. So I'll end there.